Hey everybody, welcome to BFR Tuesday. My name is Cara, and I'm hanging out here in Dallas, Texas in my clinic, Body Balance Park Cities. If you're seeing this as a replay, that probably means that you're on my YouTube channel. So do me a favor, hit that subscribe button because it helps me out, helps me share and do other things. If you're live, let me know you're here and that you're getting everything you need to by just saying hello. So I'm going to type hello into the chat. So if you want to talk to me and ask questions, go into the chat area. Hi, Liam. Handouts, I have put in what we're going to talk about today, which is lower limb reliability of LOP in different positions. I posted this on Instagram this week, and I'm playing around with some infographics. So I'd love to get some feedback on how you like these infographics. Could it be more clear, like things like that? So I'll share that. We're going to talk about the importance of finding personalized limb occlusion pressure in different positions based on what exercise programming you're going to do. What else are we going to talk about? Maybe we'll talk about some influences on what affects limb occlusion pressure. And yeah, that's about it. We'll see where that takes us. Before I get started, anybody have any questions for me before we get going on what I wanted to talk about today? All right. Guess everybody's doing well. Looks like the handout has been clicked, so you guys are getting that. Excellent. I like to provide those studies for you so you can see. Makes life a lot easier. Okay. So I'm going to share my screen. And let's share. I'm going to go back and forth because sometimes this doesn't work and I just want to see if this works. So I'm going to put up the picture, and everybody that's live, please let me know if you're seeing this. So when I do it this way, Liam, okay, so you can see the arterial occlusion pressure and body position in lower limb. Okay, great. Okay, that's kind of cool. Okay, so what that means is technology is pretty cool. That means that I can see questions as they come up, whereas before I couldn't. So as long as you guys are seeing that, that's awesome. Okay, so what we're going to do is let's talk a little bit about what Hughes and his cohorts found. So what they're looking at is they wanted to see what the difference is in limb occlusion pressure or total occlusion of the artery, which is defined as your limb occlusion pressure. So let me kind of just back it up a little bit. So I've got my cuff. And I put the cuff on. This is too big for my arm, but I don't want to do my leg. Okay, so I've got this here. Right now, I have 100% arterial flow into my arm, and I have 100% venous return back to my heart. 100% arterial flow, oxygenated blood, 100% venous return back to my heart. Now I inflate the cuff, and I keep inflating, and I keep inflating, and I keep inflating. I'm actually just going to demo this. Let me grab my... Okay. So I've got my size 2 cuff. I wish I needed a size 3 cuff for my arm, but feeling like it's getting more and more like I need a size 1 cuff. Good. All right. So I got my cuff on. I put that on as tight as I can to start, and I only put it in this position. So now I'm going to connect my pump, and I'm going to inflate this. You know what? I'm going to get my Doppler. Okay, so I've got my Doppler, turning it on. Probably can hear it. I'm going to find my radial pulse. And now you're going to hear so there's my heart rate. Okay, now I really don't know how I'm going to do this now. I'm going to try to relax my arm and see if I can inflate while still keeping this. I don't think I'm going to be able to. This is definitely a challenge. All right, there we go. So you hear it. Now I'm going to inflate this fig. Okay, pulse goes away. That is your limb occlusion pressure. Now I went a little bit past it, so I'm going to let a little air decrease a little bit. There it comes back. So that was 140. Upper extremities typically going to be 120 to 160 or so. Okay, so that's your LOP. We don't exercise at LOP. There are some protocols at 100% LOP, but not very many, and we usually reserve those just for the clinical setting. Then what I do, so is everybody cool with that's limb occlusion pressure? The amount of pressure required in order to fully occlude. Now, right now it's inflated. I no longer have a pulse here. You can't feel a pulse. It's not here. That means that I have no blood flow in and I have no blood flow out. Okay, so that's 100% occlusion. All right, it's getting tight, so I'm going to release it. So now, what these authors wanted to find out was, hey, in different positions, does it influence your limb occlusion pressure? Because if it doesn't influence it, then we can just do it in one position. So they did it in supine, they did it in seated, and they also did it in standing. And so here are the numbers. So you're seeing in this supine position, they got 187 plus or minus 32.5. That was a standard deviation. 204 plus or minus 28.5. And then here you have in a standing position, 241 plus or minus 49.3. So you can kind of look at these and go, okay, well, so in a lying position, your limb occlusion pressure is much lower. Why would that be? What are things that influence limb occlusion pressure? Number one, time of day totally will influence it. Okay, so if it's later on in the day, it's probably going to be a little bit higher. It's going to be a little bit higher if you're male over female. It'll be a little higher based on the size of your limb. It'll be higher depending on the width of the cuff. Next week, I'm going to talk about cuff width, but just dropped my gel. But the width of the cuff is going to make a big difference. And one of the reasons we went with a wider cuff is because it requires less pressure to reach LOP, meaning that you need less pressure on the limb, which means that there's less risk of injury beneath the cuff. If I half this, then there's going to be a lot more pressure in order required, and I'm going to show some literature next week, to create LOP. And then if you're training at 50%, which is what we do in the upper extremity, typically 60 to 80% in the lower extremity, then you're going to need a lot higher pressure, which increases your risk of injury beneath the cuff. So we'll talk about all that next week. But those are all things that influence position. But position is big time influencing, because when I'm standing, my muscles are having to contract at about 30% maximal voluntary contraction in order to keep me upright, just to fight gravity. So that muscle contraction is going to require my body or is going to require more pressure to get to the artery in order to fully occlude. In a seated position, it's a little bit elevated, but not much. In a supine position, it is the least. So the reason that I put these pictures here, if somebody's going to be doing standing exercise, my belief is that, in my philosophy, is that you should do a standing LOP. If you're going to be exercising in seated, you do a seated LOP. And if you do an exercise in supine or prone or side lying, let's say, then you do a supine LOP. I also recommend that you do it on both sides. You will see drastic differences. If there are drastic differences, and I'm not sure what these numbers are, I had a physician that's a friend of mine contact me yesterday after I posted this, and he thought that I should be making sure people understand if there's a big difference left to right, there might be more atherosclerosis, or there might be another issue in, and they should be screened a little bit more thoroughly, especially in the elderly population, or there could be a cardiac issue. So what that number is, I don't know yet. I'm going to do a little bit of research. He talked a little bit about, if you look on my Instagram feed, a little bit about I think it was an ankle brachial ratio. I got to see. I don't know anything about it. He is a radiologist, so I'm going to do a little bit more digging and see what I can find. I have not seen huge differences left to right. And when I say huge, bigger than about 20 millimeters of mercury. And most of the time, I think that's because if one arm is dominant, it might be more muscular. The other reason I think is that sometimes we have atrophy in one limb because of disuse or because it's been in a cast, and that limb will be smaller so that the pressures will probably be a little bit lower. So that might be creating some of the differences left to right, but I always do it bilaterally. If they are within 10 millimeters of mercury left to right in that position, then I consider them the same, because by the time that you do a percentage of that LOP, so for example, if I inflate my cuff here and I got to 140, that's my LOP. I don't exercise at that. I exercise at 50% of LOP. So then what I would do then is reduce the pressure to 70, half of 140, half of the limb occlusion pressure. If I do it on this side and it's, let's say 180, that difference, I would treat them as two different limbs. But if this is 140 and this is 145, or this is 150 within 10 millimeters of mercury, then I'm going to treat them as the same limbs. I'm going to chart that in their notes, and I'm going to just use one pressure both sides to make my life a little bit easier. But I'm going to document what their LOP is, and I'm going to document in their medical record, LOP was established using a Doppler based on industry standard. This is what it was on this date. And then I'll reevaluate that usually after about 3 sessions, because people start to adapt, and then after about every month. Now, I have to admit, when like today I had a patient come in this morning, he's an older gentleman and he has a drop foot that I'm treating, and I'm doing a little dry needling, I'm doing a little bit of massage, I'm trying to stimulate the area with electricity and the needles, and then I'm adding BFR, and I'm doing just my hands, really, because that's all he can tolerate is as the resistance. And I'm trying to recruit motor units, right? Trying to get more motor units firing and get that thing stronger, and also affect pain levels, because it does reduce his pain. With him, I tested every dime. Like it takes me 1 minute. I mean, it doesn't take me any time. So why not know what his LOP is there in case it is variable? Maybe last time he had a office visit and it was 8 in the morning, and this time it's at night. It wasn't that case. He's always at 9 o'clock in the morning. But regardless, because he's older, I tend to test it each time, and then I'm being as accurate as I can. And literally it takes me 30 seconds. So why not just go that little extra mile for your patient's safety and efficacy? Okay, so summary: establish LOP in the position that the patient or client is going to exercise in, reestablish it, do it bilaterally, make sure there's less than 10 millimeters of mercury each side. I might have to update that. This is just me with my clinical experience. I haven't seen anything in the literature about this. And reestablish that every so often. And, if it makes you feel more comfortable, just do it each time. It's quick and easy. Otherwise, document it in your notes that you use the gold standard, which is the Doppler. Now, some of you guys don't have Dopplers, and believe me, I can't wait until we no longer have to use a Doppler. And we will just be using the built-in pump that has a Doppler built in. But until then, if you don't have a Doppler, you can use a pulse. I am still searching for another way to estimate it based on maybe blood pressure or something else. I just can't find it, and it's there's nothing that's accurate, and that's why they use Doppler as a gold standard. Okay. What questions does anybody have about what we're chatting about? Please, please, please type it in here in the chat. Let me know, what do you think about these graphics? Like, I really like this. I think it looks good. It stands out. Nice white background. I think it's pretty clear. I think you can kind of look at it and go, okay, yeah, I think, so I really like the work that my guy did on this. Oh, cool. Graphics help a lot. Great. Love it. Thanks. Any questions for me? Nothing? Okay. So I like to keep these between, 15, 20 minutes. Last week, I went a little bit longer with Peter Holman, talking about his total knee reconstruction and his experience. But I'm going to try to keep it here to about 15. I got patients in a couple minutes. I like to enjoy my shake for my lunch. I really appreciate everybody coming on and asking questions and commenting. And please let me know if you have other questions you would like me to address. I just kind of address things as they come up and as I'm researching and doing work, and just kind of doing a share or kind of a behind the scenes. But I'm happy to talk about whatever people have questions about. And again, I appreciate you and much gratitude. And I hope you were able to learn something from this. Thanks so much.